Hello, my name is Rebecca Shatsky, and I am an associate professor at the University of California, San Diego Moores Cancer Center. I will be discussing 4 posters today on novel immunotherapy approaches to the treatment of early stage and late stage breast cancer. Here are my disclosures. These are the 4 posters I will be discussing today. The first 2 posters discuss the use of immune checkpoint inhibitors in combination with radiotherapy, presumably in hopes of achieving an abscopal effect. The abscopal effect refers to the ability of localized radiation to trigger systemic anti-tumor effects. Since the addition of immune checkpoint inhibitor therapy to the anti-cancer armamentarium, there has been a resurgence of interest in this theory, as localized radiation similar to immune checkpoint inhibitors can prime the immune system by releasing pro-inflammatory cytokines, tumor-associated antigens, and activate dendritic cells, thereby enhancing antigen presentation and the priming of T cells. This makes radiation therapy a prime target for the combination with immune checkpoint inhibitor therapy for potential synergistic activity. The first poster I would like to discuss is the PEARL trial, preoperative pembrolizumab with radiation therapy in early stage triple-negative breast cancer by Heather MacArthur et al. Here is a schematic of the PEARL study trial design. This was a single institution phase 1B/2 study. It enrolled 50 stage 1 through 3 triple-negative breast cancer patients who received pembrolizumab at a dose of 200 milligrams IV times 1, followed by 3 weeks later pembrolizumab again, this time with radiation therapy at a dose of 24 gray in 3 fractions to the primary breast tumor. This was followed by neoadjuvant chemotherapy of physician's choice, then by surgery, and potentially by radiation therapy if indicated, although without an additional boost to the breast tumor. Importantly, triple-negative breast cancer was defined as less than 10% ER/PR positivity and HER2 negative. PD-L1 in this positive was defined in this trial by the DACO 22C3 assay with a combined positive score of greater than or equal to 1. And paired tumor biopsy and blood samples were taken pre-treatment and after cycle 1 and 2 of pembrolizumab. The primary objectives were safety and tolerability, change in PD-L1 and TIL score, and the secondary objectives were pathologic complete response rate, safety and toxicity up to 1 year after study enrollment. And safety and tolerability, importantly, were defined in the primary objective by the number of patients who did not require a delay in standard of care neoadjuvant chemotherapy or surgery. PEARL trial patient characteristics. The median age was 55 years, but importantly in this trial, the age range was very wide, ranging from 26 to 93. 92% of patients were stage 2, 32% were node positive. Chemotherapy of physician's choice regimens varied greatly, although 80% of patients received an anthracycline and 48% of patients received carboplatin. 36 out of 50 patients only had patient tumors that were evaluable for baseline PD-L1 and TIL quantification. The PEARL study results. The overall PCR rate was 56%, although 74% were able to achieve a residual cancer burden score of either 0 or 1. Toxicities. Only 4 patients had grade 3 toxicity attributable to pembrolizumab. 1 patient had adrenal insufficiency, 1 colitis, 1 pneumonitis, and 1 hyponatremia. No patient experienced a delay in the initiation of neoadjuvant chemotherapy due to pembrolizumab radiation therapy, which again was the primary objective. Importantly, the PD-L1 positive population in this trial was a little different than prior either early stage or metastatic stage triple negative breast cancer trials, in that 86% of those evaluable, even though there are small numbers and only 36 evaluable tumors, were considered PD-L1 positive at baseline. Neither PD-L1 or TILs, however, seem to correlate with treatment response. But again, this should be interpreted with caution due to small numbers. Poster number 2, a randomized phase 2 trial of single fraction or multi-fraction stereotactic ablative body radiotherapy with atezolizumab in patients with advanced triple negative breast cancer, the SABCS study by Stephen David et al. Here is a trial schematic of the SABCS study. This was a multi-center open label phase 2 randomized trial that enrolled 50 patients with locally advanced or metastatic triple negative breast cancer who had received 0 to 1 prior lines of chemotherapy in the metastatic setting. Stereotactic ablative body radiotherapy was given to patients in each arm to 1 to 4 sites of metastatic disease with at least one site left untreated. Patients were randomized to one of 2 arms of radiotherapy. The arm 1 consisted of 1 fraction of radiotherapy in 20 gray, which was followed sequentially by atezolizumab therapy. Arm 2 was 3 fractions with a dose of 24 gray, followed sequentially by single agent atezolizumab therapy. The primary endpoint was progression-free survival. Secondary endpoints included efficacy per PD-L1 population, TIL quantification, response assessment, overall survival, and safety. PD-L1 positive in this trial was defined using the Ventana SP142 assay of greater than 1% or greater than or equal to 1%. Aztec trial patient characteristics. The median age was 57. 40% of patients had no prior chemotherapy in the metastatic setting. 60% had received 1 prior line of chemo, and 35% of patients were PD-L1 positive, which, as opposed to the Pearl study, is more consistent with other, at least metastatic triple negative breast cancer PD-L1 positive populations. Aztec study trial results. Toxicity between the 2 arms was similar and notably pretty minimal. Median progression-free survival, however, for the 1 fraction versus 3 fractions was similar, but the progression-free survival was fairly modest, 2.5 months versus 3.1 months. Progression-free survival by PD-L1 status and TIL greater than 5% or less than 5% was similar and not statistically significant. Toxicity in this trial, again, was notably low in that less than 10% of patients experienced a grade 3 toxicity. The most common grade 3 adverse event was fever, which occurred in only 6% of patients. The next 2 posters involved the combination of immunotherapy, immune checkpoint inhibitors, and novel targeted therapies. Specifically, combinations include PI3 AKT P10 pathway inhibiting agents and a novel anti-CD73 monoclonal antibody in combination with immune checkpoint inhibitors and chemotherapy. The PI3 kinase AKT pathway drives anti-apoptotic signaling in breast cancer through activating mutations, copy number alterations, and in addition to direct anti-neoplastic activity, there is a growing body of evidence that agents targeting the PI3 kinase AKT pathway may have indirect activity mediated through the host immune response, which theoretically would make them prime agents to combine with immune checkpoint inhibitors. In addition, in the Begonia trial, the trial utilizes a novel anti-CD73 monoclonal antibody, oleclumab, that blocks the conversion of AMP to adenosine. The presence of extracellular adenosine is believed to mediate the immunosuppressive effects of both regulatory T cells and myeloid-derived suppressor cells. And in addition, extracellular adenosine within the tumor microenvironment has been described as preventing anti-tumor immunity, and preclinical studies and ongoing studies in the non-small cell lung cancer space led to the addition of this agent in the hopes that it might synergize well with immune checkpoint inhibitors. Poster number 3, the Begonia trial, a phase 1b/2 study of durvalumab combinations in locally advanced metastatic triple-negative breast cancer. Results from arm 1, durvalumab plus paclitaxel, arm 2, durvalumab plus paclitaxel plus capivasertib, and arm 5, durvalumab plus paclitaxel plus oleclumab, Peter Schmidt et al. This is a trial schematic of the Begonia trial provided by Dr. Schmidt's team. Key eligibility criteria were that this was a first-line trial for locally advanced unresectable or metastatic triple-negative breast cancer, and that patients must not have relapsed within 12 months of taxane therapy that was used in the early breast cancer treatment setting. Importantly, as far as dosing is concerned, in arm 1, a dose of 90 milligrams per meter squared of paclitaxel, 3 weeks on, 1 week off, was used. Durvalumab in all arms was given at a dose of 1,500 milligrams IV once monthly. In arm 2, there were 2 doses of paclitaxel used, a 90 milligram per meter squared dose and an 80 milligram per meter squared dose, 3 weeks on, 1 week off in both. Capivasertib was given at a dose of 400 POBID, days 2 through 5, for 3 weeks on, 1 week off. So a complicated dosing schema, which is typical of some AKT inhibitors. And then oleclumab was given at a fixed dose of 3,000 milligrams IV days 1 and 15 in the first 2 cycles as a loading dose, and then monthly thereafter. Primary endpoints for this trial were safety and tolerability. Secondary were objective response rate, duration of response, progression-free survival, overall survival. Exploratory endpoints included PD-L1 expression, PI3 kinase pathway alterations, CD73 expression, and associations of the above with treatment benefit. Begonia trial results. Responses importantly occurred in both PD-L1 positive and PD-L1 negative groups in each arm. Responses were similar with the 80 milligram per meter squared versus 90 milligram per meter squared paclitaxel dosing, highlighting that the 90 milligram per meter squared may not be necessary as seen in many other metastatic trials over the past 20 years. The durvalumab paclitaxel capivasertib arm had a high rate of grade 3/4 adverse events, with 73.3% of patients experiencing grade 3 to 4 adverse events, most notably diarrhea, nausea, vomiting, and rash. There was no clear correlation between treatment response and PI3 kinase pathway alterations or CD73 expression, but results should be interpreted with caution due to small numbers. And overall response rates, importantly, were similar in the durvalumab paclitaxel doublet arm versus the triplet combinations of durvalumab paclitaxel capivasertib and durvalumab paclitaxel oleclumab. Poster number 4, the Morpheus trial. This was a phase 1b/2 open label randomized trial of atezolizumab with ipatasertib and fulvestrant versus control in Morpheus HR positive, and atezolizumab with ipatasertib versus control in Morpheus triple negative breast cancer, MTNBC, Sarah Hurwitz et al. This is a trial schematic of the Morpheus HR positive trial and the Morpheus TNBC trial of the arms presented. This was provided by Dr. Hurwitz's team. Morpheus HR positive is a second or third line metastatic trial of patients who had received prior CDK4/6 inhibitor therapy and no prior fulvestrant in the metastatic setting. Patients were randomized to either atezolizumab plus fulvestrant, atezolizumab ipatasertib fulvestrant, or fulvestrant alone, the control arm. In the Morpheus TNBC trial, it was the arms presented are the second line metastatic locally advanced TNBC that was immune checkpoint inhibitor naive, and patients were randomized to atezolizumab plus ipatasertib versus capecitabine at a dose of 1,250 milligrams per meter squared, the control arm. Morpheus trial results. Treatment with atezolizumab plus ipatasertib plus fulvestrant resulted in an encouraging preliminary efficacy signal. This is encouraging as many hormone-positive patients, as we know, have PI3 kinase pathway alterations. And in the hormone-positive setting, PI3 kinase inhibitors such as alpelisib have already been seen to show intriguing efficacy in this patient population. Treatment with atezolizumab ipatasertib resulted in only a limited response in patients with triple-negative breast cancer. In the TNBC study, no associations were observed between any of the evaluated biomarkers and disease response. It should be noted that in neither the Begonia trial or the Morpheus trial, patients were specifically required to have alterations in the predefined biomarker pathways. So what can we conclude from the four posters presented today? So combined immune checkpoint inhibitor and radiotherapy in the neoadjuvant or advanced setting appears to be safe and well tolerated. Notably, in even patients of a very advanced age, in the Pearl trial, notably a patient of the age of 93 was able to tolerate therapy seemingly without issue. This is important as it may be a future de-escalation strategy of cytotoxic chemotherapy, as noted by Dr. MacArthur in her poster. Both the Begonia and Morpheus trials reported little improvement in response with the addition of AKT inhibitors to metastatic triple-negative breast cancer. This is consistent with the results of the phase 3 Opportunity 130 trial, although differs from the smaller phase 2 positive Lotus and PACT trials. Importantly, AKT inhibitors continue to show considerable toxicity. Consistent with other trials, greater than 50% of patients receiving AKT inhibitors in Begonia and Morpheus had grade 3 or 4 treatment-related adverse events. Given the considerable toxicity we are seeing with these agents and the very limited efficacy in metastatic triple-negative breast cancer we are seeing, one has to wonder if the risks outweigh the benefits. Finally, all 4 studies use a variety of different PD-L1 assays and report highly variable levels of baseline PD-L1 expression. And this highlights to me the need for consistency across the field and not only selecting a PD-L1 assay to use. As we know, there are differences between the different assays, and some patients may test positive with one assay and not with another, which is quite problematic when we're using these two as inclusion and exclusion criteria that insurance companies will use after approval. We know the same is true when it comes to PD-L1 testing on different metastatic sites throughout the body. So until we iron out some of these biomarker details, patient and therapy inclusion and exclusion criteria based on PD-L1 testing remains fraught with significant problems. I would like to thank the SABCS Planning Committee for inviting me to present today this poster discussion, and especially like to thank Drs. MacArthur, David, Schmidt, and Dr. Hurwitz for allowing me to evaluate their posters and providing them to me in advance. Thank you.